All right, so we will go ahead and get started. This is Antiepileptic Drug Use Patterns in Suspect Epileptic Dogs among Neurology and Emergency Specialists. This paper was also published back in 2017, I believe, 2018 of February, and it's out of JAHA. So let's go ahead and get started.
Antiepileptic Drug Use Patterns in Suspect Epileptic Dogs among Neurology and Emergency Specialists. This study used a cross-sectional survey designed to inquire about antiepileptic drug use in newly diagnosed idiopathic epileptic dogs among board-certified emergency and neurology specialists. Results were obtained from 300 completed surveys by 128 board-certified neurologists and 172 board-certified emergency and critical care specialists. Case volume was slightly different between groups, with 36% of neurologists and 18% of ECC specialists managing 0.50 cases of first-time canine seizure patients yearly. The initial AED of choice was similar between the groups, with 66% of neurologists and 64% of ECC specialists using phenobarbital and 16% of neurologists and 26% of ECC specialists using levetiracetam. Although most respondents gave a loading dose of phenobarbital, roughly one-fourth of neurologists did not load the drug versus 6% of ECC specialists. The total loading dose was similar between respondents, but varied in administration protocol. Approximately half of neurologists and nearly two-thirds of ECC specialists gave a higher initial dose of levetiracetam than recommended. Almost all the respondents who gave a higher initial dose of levetiracetam used 60 mg per kilogram IV-1s. Understanding the common practices in AED use may promote future discussions regarding best practices in the management of canine idiopathic epilepsy.
So for me, it's no surprise that there's a difference between this just based on my clinical experience, but let's go ahead and get to the meat of the article.
Introduction. Epileptic seizures are one of the most common canine neurological disorders presented to veterinary neurologists and emergency and critical care specialists, characterized by spontaneous recurrent seizures originating in the brain. The prevalence of idiopathic epilepsy in the canine population ranges in the literature between 0.5 and 5%. Previously classified as primary epilepsy, it was defined as epilepsy where no structural cerebral pathology is suspected. However, the International Veterinary Epilepsy Task Force proposed terminology and classification of epilepsy and epileptic seizures that suggests that IE is the current term to use for epilepsy that is proven or suspected from genetic background, or the cause is unknown, and there is no indication of structural epilepsy. The first onset of seizure activity in dogs with IE is typically between 1 and 7 years of age. If IE is suspected, antiepileptic drug therapy is often initiated. Although there is no cure for IE, improvement in quality of life can be obtained in most cases. There is a limited selection of AED therapy available for use in veterinary medicine. However, the commonly used drugs appear to be effective in controlling the generalized seizures typically observed with IE. The goal of AED therapy is to provide an appropriate balance between seizure control and side effects of the drug for the individual patient. There are multiple AED options available, and ultimately, the choice of treatment depends on clinician efficacy, safety, and price. The American College of Veterinary Internal Medicine Consensus Statement on Seizures discusses the medications available and gives general recommendations for when to initiate treatment. Their recommendations are that AED therapy should be initiated when the following occurs: identifiable structural lesion present or prior history of brain disease or injury, acute repetitive seizures or status epilepticus, 2 or more seizure events within a 6-month period, and prolonged, severe, or unusual post-ictal periods. However, as the goal of the consensus statement was to recommend maintenance AED, but not necessarily emergent treatment of seizures, it does not discuss recommendations for loading doses or higher initial doses of the drugs. A loading dose is a larger initial dose or series of such doses given to rapidly achieve a therapeutic concentration of the drug in the bloodstream.
I think that's a very good summary of the ACVIM consensus statement, but for anyone studying for boards, it's definitely worth going through and getting just all the information from that consensus statement. It's really good.
The author's knowledge: there is no information available in the literature regarding which first-line AED specialists actually elect to use for treatment of canine patients with new-onset seizures. Determining which drugs are commonly used may allow the creation of well-accepted therapeutic protocols. The intent of this study was to ask specialists how they treat dogs with new-onset seizures who have not previously received AEDs. Treatment patterns may differ between ECC and neurology specialists, as different populations of first-time seizure patients likely present to the two groups. The goal of this study was to document AED use patterns for dogs with new-onset seizures due to suspected IE among board-certified ECC and neurology specialists. Use patterns considered in the study include the first-line choice of AED as well as initial and maintenance dosing of the drugs, materials and methods. This is a descriptive study. A survey was designed to acquire information about AED use and clinical referral practice. All questions were related to first-time seizing dogs newly diagnosed with suspect IE. The University of Florida Institutional Review Board determined the study exempt from approval before conducting the research as required for human subjects research. The questionnaire was formatted using the software program Qualtrics on the web-based site through the University of Florida. Qualtrics is a secure site, and all data that respondents provided through this program was anonymous and encrypted for Security purposes using secure socket layers. The survey contained up to 20 questions with multiple choice options provided for each question using a checkbox method or fill in the blank option for individualized responses. Questions pertain to the respondent's specialty training, current practice, year practicing, number of seizure cases managed per year, and first-line AED of choice. Depending on the selected AED of choice, questions specific to that drug were prompted, including information about initial and maintenance doses as applicable. The beginning of the survey required each respondent to give informed consent prior to answering any questions. The survey was launched in November 2016 and distributed to diplomates on the databases of the American College of Veterinary Emergency and Critical Care and the ACVIM via email listservs of their respective specialty colleges. The American College of Veterinary Emergency and Critical Care listserv contains 639 email addresses, and the ACVIM Neurology discussion listserv contained 361 email addresses. General practitioners were not included in the study. Respondents were given one mode to complete the survey prior to closing the study and collecting data from the completed responses. Basic descriptive statistics were performed on the information obtained. Results were obtained from 300 completed responses consisting of 128 board-certified neurologists and 172 board-certified ECC specialists. The majority of respondents from both groups described the environment where they received their specialty training as either academic or private practice, and a few selected other, representing non-traditional programs. Additionally, most respondents currently practice their specialty in a private practice environment when compared with academic settings or industry/other. Neurologist respondents varied, with 37% having completed their residency within the last 5 years, 22% 5 to 10 years ago, 30% 11 to 25 years ago, and 11% 0.25 years ago. 44% of ECC specialist respondents completed their residency 5 years ago, 32% 5-10 years ago, 23% 11 to 25 years ago, and 1% 0.25 years ago.
It's definitely interesting that most of the neurologists were a little bit older compared to the ECC specialists, which seem to be younger.
Case volume also differed between groups, with 36% of neurologists and 18% of ECC specialist respondents managing 0.50 cases of first-time canine seizure patients per year. Once demographics were obtained, results for AED therapy were assessed. The initial AED of choice was similar between groups, with 66% of neurologists and 64% of ECC specialists using phenobarbital as their first-line medication. Respondents from the neurologist group selected levetiracetam as the second most commonly used initial AED of choice, and 16% zonisamide at 15%, bromide at 1%, and other at 2%. ECC specialists also responded with levetiracetam at 25.5% as the second most commonly used initial AED, followed by zonisamide at 9%, bromide at 1%, and 0.5% with other. The other option from both groups revealed individualized responses, generally stating that all may be appropriate options and that the choice was dependent on each individual case and circumstance. The individual breakdowns based on AED of choice for respondents regarding residency training environment and current practice environment were not assessed in this study.
So it does make me a little bit happy that zonisamide is lower on the list, both for the neurologists and also the ECC specialists, just because we have little evidence of its efficacy, and using it as a first-line therapy is not recommended in the ACVIM consensus statement or in the Epilepsy Task Force consensus statement.
Study. If phenobarbital was selected, when asked about protocol for loading, most respondents selected that they did administer a loading dose of the drug when indicated. The results for this, and all survey options for loading dose, are provided in Figure 2. Of the 82% of respondents who indicated they'll load phenobarbital, the total loading dose was similar between responders but varied in administration protocol. Respondents who selected other for loading dose options all still loaded but used a different protocol than those offered in the multiple choice options. Therefore, they were included in the overall number. Their protocols varied but typically consisted of administering 2 to 4 milligrams per kilogram aliquots over varying hours until reaching total desired loading doses of 16 to 20 milligrams per kilogram IV or per Os. 26.
And that's something I typically don't do unless I'm doing an oral load. If I'm giving it IV, I'll usually just give the 15 to 20 mg per kg as a bolus.
26% of neurologists did not load the drug, whereas only 6% of ECC specialists did not give a loading dose. When electing to load, 52% of neurologists gave a higher initial dose than the recommended starting maintenance dose of levetiracetam, leaving 48% that do not give a higher initial dose prior to starting the patient on a maintenance dose when indicated. 68% of ECC specialists gave a higher initial dose of levetiracetam, whereas 32% of them did not.
That's shown in Figure 3, but just a comment on some of these findings. So for potassium bromide, it is something I'm starting to use with a little bit more frequency. It's still not maybe my first line of choice, but I have had success with the loading dose of 625 mg per kg, and I divide that up over about 5 days, and most dogs seem to tolerate that pretty well. As far as the Keppra, I usually give a higher dose, at least when it comes to maintenance. The 60 mg per kg is usually my initial IV loading dose, There was that one paper that described giving, I think it was 100 mg per kg loading dose, and the dog did have a little bit of hypotension associated with it. That's not anything that I've ever experienced, but again, I'm usually giving the 60 mg per kg dose as my starting dose. So let's see what they have in the discussion.
Discussion. The 2015 ACVIM Small Animal Consensus Statement on Seizure Management in Dogs states that the selection of AED should be based on a number of factors, including seizure type, efficacy, and tolerability. The consensus statement was based on current literature and clinical expertise. The current study reports the first published evaluation of practice patterns in the administration of AEDs by veterinary neurologists and ECC specialists in canine new-onset seizure patients. Many similarities in practice were discovered between specialties. Phenobarbital is used most commonly by both groups, and bromide is rarely the initial AED of choice. The 2015 ACVIM Consensus Statement on Seizure Management in Dogs may be a contributing factor, as it recommends phenobarbital, but not levetiracetam, as a first-line drug. Based on the level of evidence to date, this is also likely due, at least in part, to its familiarity in veterinary medicine. However, levetiracetam also appears to be used by both ECC specialists and neurologists. Benefits of levetiracetam include its unique mechanism of action and minimal adverse effects. The fact that the drug must be dosed every 8 hours is likely part of the reason it is not more frequently used because of concerns of owner compliance. However, the survey did ask respondents if their choice was levetiracetam and the patient was the appropriate size to be dosed using extended-release levetiracetam every 12 hours, would they use/recommend the formulation? All respondents who selected levetiracetam stated that they would recommend the extended-release formulation if appropriate. Additionally, studies on levetiracetam for dogs with epilepsy tend to evaluate its use as supplemental treatment in dogs refractory to phenobarbital, bromide, or both, rather than as an initial AED choice. There is one study that compared levetiracetam with phenobarbital as a first-line drug. That was the first study to investigate levetiracetam as monotherapy for canine epilepsy and found that levetiracetam did not result in a 50% reduction in seizure frequency in any patient at dosage used. However,
and that's one of the main reasons I don't use levetiracetam as my first line, because it seems to, at least when you look at it long term, it has a poor overall efficacy for controlling seizures.
However, a major limitation to the study was sample size. Also, the dose they administered was 10 milligrams per kilogram 3 times a day, which is lower than the currently recommended initial dose for maintenance treatment provided by ACVIM consensus statement. Thus, more studies regarding the use of levetiracetam as a single agent for treatment of epilepsy are suggested. This study highlights some differences in approach to seizure management between the two specialties that may warrant further exploration. Specifically, there was discrepancy in the number of ECC specialists and neurologists who load phenobarbital. This may be because of each respondent's individual interpretation of the questionnaire, which did not specifically ask whether the clinician loaded phenobarbital but rather asked how they did. It is also possible that patients' presentation may vary drastically between canine patients presenting with IE for the first time to ECC specialists versus neurologists. Thus, respondents may have answered the questionnaire differently depending on their reaction to the questions or based on the patient's population they typically treat. Retrospectively, the author should have made clear clarifications as to whether seizure activity was occurring at presentation for the hypothetical patients. The intent was to elicit responses about cases that were systemically healthy dogs presenting for seizures but not currently experiencing clusters or status epilepticus. As a result, fewer neurologist respondents may have elected to load phenobarbital in comparison with their colleagues if they interpreted the question as pertaining to the non-emergent seizure patient. It is impossible to determine this based on the current study. However, it is difficult to apply the same logic regarding levetiracetam, as bolusing a higher initial dose of the drug is not a widely accepted therapeutic option regardless of patient presentation, although this practice does appear to be common at some institutions. Although the ACVIM consensus statement does not give recommended initial higher doses for phenobarbital, it is recognized as a loadable drug as a result of its pharmacokinetics. The IVETF consensus proposal for medical treatment of canine epilepsy in Europe briefly discusses loading doses. It states that in animals with cluster seizures, status epilepticus, or high seizure frequency, phenobarbital can be administered at a loading dose of 15,220 milligrams per kilogram IV, intramuscularly, or per os divided in multiple doses of 325 milligrams per kilogram over 1 to 2 days
So the computer messed up there in what it was saying. So the loading dose, as I said earlier, 15 to 20 mg per kg IV. It does say you can give it intramuscularly, but at least the way that it's formulated here in the United States, it should not be given that way. And the multiple dosages of 3 to 5 milligrams per kg over 2 days is what it's supposed to say.
days regardless of its previous recommendation. The current study found that 16% of overall respondents gave the loading dose in one single dose, which is consistent with historical pharmacokinetic studies, rather than divided over time. However, most respondents actually appear to be following the IVETF recommendations of a divided load. The ACVIM consensus statement does not comment on administering a bolus of an initial higher dose of levetiracetam prior to maintenance. In fact, this is rarely discussed. In literature, one study discusses administering a higher initial dose of levetiracetam for pulse therapy protocols, but not when initiated as a maintenance drug. There is one study that trialed levetiracetam for the emergency treatment of seizures in dogs at 60 mg per kilogram IV. It stated that plasma concentrations of the drug were predicted to be within the proposed therapeutic therapeutic range for W9 hour when that initial higher dose was administered, suggesting it is likely useful in emergency settings for seizure control. It is not traditionally considered a loadable medication because of a relatively short elimination half-life and high oral bioavailability, which is why administering a higher dose is not recognized as necessary or appropriate among all specialists. However, the previously mentioned study by Hardy et al. Demonstrated that administering a higher dose of levetiracetam will increase plasma concentration, suggesting that this should be recognized by specialists when electing a dose to administer additionally. In the study by Moore et al., elimination half-life and clearance data were determined to be similar and independent of route of administration, as levetiracetam has a high bioavailability that allows for similar blood concentrations of the drug to be achieved. This suggests that the route does not affect the pharmacokinetics of the drug either. Thus, if it is decided to give an initial higher dose of levetiracetam by the clinician, it can be administered orally or intravascularly to the same effect. As stated previously, a major limitation to this current study is the interpretation of the questions in the survey by respondents. Likewise, formatting of the questions could have led to the potential for bias in this study. Additionally, this report only considered AED use by neurologists and ECC specialists. However, internists and general practitioners also treat dogs with IE, and evaluation of their practice patterns should be considered in future studies. It should also be pointed out that IE may present differently between neurologists and ECC specialists. Anecdotally, ECC specialists may see undiagnosed, first-time seizuring dogs more commonly, as these patients often present as emergencies. Therefore, it may also be assumed that neurologists often see the uncontrolled epileptic patients previously diagnosed by another veterinarian, or those wishing for a more complete workup to rule out other causes of the seizures. Because of this, it would be interesting and useful to survey general practitioners regarding their AED use. Conclusion. Although previous literature, including the ACVIM consensus statement, provides information about individual AEDs and their effects in dogs, this is the first study that reports what specialists are currently using in practice. Phenobarbital is the most frequently used AED in first-time suspect IE dogs, followed sequentially by levetiracetam, zonisamide, and, rarely, bromide. The results should not be described or interpreted as standard of care or expert opinion, but rather used to help identify further areas of exploration related to AED use in veterinary medicine.
I think that last part of their conclusion is important, as this should not be used as recommendations, but still interesting study. I also think that what they talk about with their limitations, that neurologists are probably seeing a different population of patients compared to emergency critical care, is also very important. I do wonder in this study if they confirmed idiopathic epilepsy in a lot of these patients. It didn't seem like it went into detail on that. Another point that I'll make on Keppra that kind of goes along with that, there was one study that said 50% of patients with structural epilepsy respond to Keppra, but if you read through that study, it seems like none of the dogs with brain tumors responded to Keppra, so that's something else to keep in mind when using that drug. And then at the bottom it talks about we should look at what general practitioners feel as far as what drugs they're using. I did a CE recently where I discussed epilepsy and mainly focused on idiopathic epilepsy, and a lot of general practitioners prefer to use zonisamide just because they feel that it has decent efficacy. It seems safe in most patients and it's easy to use. They don't have to do blood monitoring or worry about chronically checking if liver enzymes are changing. So I do know that's something that is favored by general practitioners, at least in this area, but we don't have enough evidence for me to give a recommendation on using it. But that's all I have. Pretty straightforward article, and thank you.